Assalamu alaikum wa rahmatullah. So good morning, everyone, and thank you, Mrs. Chairman, for this kind introduction. Okay, so following the same theme of hematological manifestations in lupus, I'm going to touch upon the areas of pancytopenia in lupus, whether that is a disease activity or a drug-induced phenomena. Okay, so my objectives for today's talk is that I'm going to discuss some of the hematological manifestations in lupus and to consider the possibilities that might cause these manifestations, and just to touch upon the treatment options. So obviously these are the cell lines that we are interested in, and we are interested into the part where cytopenias is the main culprit. I mean, you might have some cytosis, but cytopenia is the commonest part that has been discussed before. So as we all know from our internal medicine training, that anemia, you have to go through microcytosis, normocytosis, and macrocytosis. That all can happen in lupus. And all of these are some of the causes that might happen with lupus. So as you can see, the anemia can happen in lupus due to some deficiencies, some nutritional deficiencies. But actually, the main two common causes that you have to address is anemia of chronic disease. It's by far the commonest cause, and then the autoimmune hemolytic anemia. Now, obviously, we do have some other rare causes like red cell aplasia, aplastic anemia, and the microangiopathic hemolytic anemia. Now, these some of the differential that you might consider if the common causes has been ruled out properly. Now, anemia of chronic disease, in summary, so basically it does happen due to persistent inflammation or secondary to persistent inflammation. So someone would argue that you have an anemia of chronic disease means that you don't treat your lupus properly, some of the argument. And the main reason for that is the decreased production of the RBCs as well as a slightly decrease in RBC survival. That would happen due to improper trafficking of the iron that is usually handled by the hepcidin protein. Now, the way you find it is basically you're going to find a low serum iron, the total iron binding capacity would be low, and the high ferritin level. The story would be a little bit different in autoimmune hemolytic anemia that actually can be seen in up to 10% of patients with lupus. Now, the thing is, actually it does kind of correlate with the disease activity. So you would find other evidence of activity in other parts of the disease itself. So the majority will be warm-mediated antibody, and then you will have the hemolysis picture. So you will have the indirect hyperbiliary, high LDH, high reticulocyte count, low haptoglobin, and the direct Coombs antibody would be positive. Now, I understand that for all us as a rheumatologist, we do understand that you might have the Coombs test positive without the presence of hemolysis. So, and that's why it was counted in the SLIC criteria. So, and as I said previously, it actually implies an ongoing inflammation. Shifting gears now to WBCs, leukopenia. So this is an interesting part because it's not uncommon to find patients with leukopenia and lupus. So it might happen up to 50%, and if you follow them enough, it could be actually higher. And the main two components would be the neutrophils or the lymphocytes. So the neutropenia, again, some would suggest that it might correlate with disease activity due to a specific antibodies against the neutrophils. Drug toxicity is also something that you should consider, as well as there is a phenotype that's interesting. So they found that patients who has a positive anti-Rho antibody, they tend to have more neutropenia. So maybe this is a phenotype that deserves to be explained. Lymphocytes, though, has been well described that it correlates with inflammation. So once you have a disease activity, sometimes you might have the lymphopenia. Keep in your mind that we use a lot of steroids in these patients, so it could be actually a side effect of steroid use and or the presence of the lymphocytotoxic antibody, which correlates with the active inflammation. Thrombocytopenia. This is the area that most of our interest actually comes. So it is common. And then just to agree upon the definition, so it's if you have the platelet count less than 100,000 in 2 or more different occasions. So it's actually prevalent. You might find it anywhere between 7 to 30% different in what cohort you are looking for. And it's particularly high in a young female with positive ANA, with highly positive ANA. Now, what's the relevance? If we do have this thrombocytopenia, what can we understand? So this was a question that was raised a long time ago by Urwitz and Gladman, whether the presence of thrombocytopenia, does it signify a worse lupus? And actually they concluded by this very old trial that it does not really have any implication in the end results. So if you have a thrombocytopenia, it would not really affect the overall mortality in lupus patients. Again, that was seen in different other trials, suggesting it doesn't have a direct impact on the mortality. However, it actually signifies a subgroup of people or patients who have higher morbidity. This is a more recent trial in terms of chronology, and actually it's from Chinese cohort. Now, what they have suggested is that patients with thrombocytopenia, who is found to have thrombocytopenia, especially if they have lupus nephritis and high SLEDAI, it would suggest an active disease. And it actually would show a patients with lower survival in the future when they analyze their cohort. So actually, as you can see, there is conflicting data. Does it really affect the overall end results or not? So the way we would like to think about it is that thrombocytopenia actually is one of two. So it's either you might have it in an acute severe thrombocytopenia, where the patient usually would be flaring up, and usually they will be responding to steroid, which is different from the other phenotype, which the patients who have chronic, long-standing moderate thrombocytopenia. So we would like to have it in two different groups, so we do understand the treatment options better. Now, the general principles on why thrombocytopenia happen in lupus patients is either you have some antibodies that would actually result into decreased production, so there will be a reduced thrombopoietin agonist receptor or thrombopoietin itself, so the antibodies will be attaching to it, or there will be decreasing survival, so the splenic clearance would be higher. So if you look at this slide, it kind of, I'm trying to summarize what could be the reasons for thrombocytopenia, or what are the possibilities that you should consider whenever you have a lupus patient. So autoimmune thrombocytic anemia, which is the most important ones that we've touched upon. We have some consumption causes. So for example, like the DIC and medication side effects. Now, as we all understand that all the list of our medications do cause thrombocytopenia. Infections are always there, so our patients, by definition, they are immunosuppressed, and then they might have or develop any infection that actually cause thrombocytopenia. Other important causes, actually, the one on the far right from the screen, which is the other autoimmune processes that I'm interested in. Microangiopathic hemolytic anemia is basically the phenomenon where you have a non-immune intravascular hemolysis. This would result in the fragmentation of RBCs in the blood film. So the one on the top supposedly showing a normal blood film. The one in the bottom actually shows the presence of the low platelet count and the fragmentation of the RBCs, which are the schistocytes. Now, when we say the TMA, which is the thrombotic microangiopathy, it's basically the microangiopathic hemolytic anemia plus thrombosis plus organ damage. So we tend to see it as the primary causes like the TTP and HUS, and we do see it also as a secondary causes, like when they happen on the background of lupus or any rheumatic diseases. Now, the TMA in lupus is an interesting part because it's mainly associated with renal flare, because usually they would affect the kidneys. They will have lower C3 level and positive anti-Rho antibodies. The ADAMS13 in these patients might be low because in lupus they might have an antibody against it, and the treatment is complex, so it goes to plasma exchange and the immunosuppressive medications. And in refractory cases, you might use oclizumab. So just to remind you, these are the pentad. And actually, if you have a look on it, you would say that all of these things happen in lupus. So you would relate why would patient delay the diagnosis of TTP, because all of these things do happen in lupus. And then if it happens, it will be a little bit difficult to make the diagnosis unless if you actually think of it. So this is just clearly to show you the major differences between the TMAs and lupus. And as you can notice, these are the most important things. The presence of the schistocytes and the hypocomplementemia that kind of differentiate between both of these diseases. Again, this is the same thing. So usually the autoimmune hemolytic anemia, sorry, the autoimmune mediated process would happen in lupus, while in the other things would be the thrombotic microangiopathy. This is just a reminder. I know that this is probably well known for all hematologists, but because we are not hematologists, so I always thought that this is important to understand. How many schistocytes do you have to have? Because you actually do know that schistocytes might happen with other conditions, so we do have to have more than 1% in order for us to call it significant, because we don't know how to read blood films, and usually they are automated, and so whenever you have the result, they will tell you it's positive, and then we think that this is it. No, actually you have to have more than 1%, so you actually have to have more clarification in that regard. Again, so this could look like a redundancy, but these are the causes of pancytopenia. And as you can see, it has been mentioned previously in the anemia causes and the thrombocytopenia causes. But what I would like to point out is to some other conditions, like the HLH and macrophage activation syndrome. So what would happen here is that you would have your usual lupus patient, but they are behaving differently. They are really in a storm. So what will happen here is that, as you can see, the RBCs are engulfed by the macrophages. And then they have all of these variety of symptoms. They might not all come together, but at least some of these symptoms might happen. So they will have the fever, they'll have the cytopenias, they will have the coagulopathy, and they will have the crazy high ferritin level. So it's always important to keep an eye on this differential diagnosis, especially when you have a pancytopenia kind of picture. So in terms of management, what are the things that we are going to use and when we are going to use it? So I'm showing you all of, probably know this, the 2019 ULR criteria, and you do understand that they divide it based on the severity of the organ involvement. Now the interesting point is actually if you go through the guidelines or the recommendation, you'll find them only talking about the platelets. They haven't really talked about the RBCs, sorry, the hemoglobin or the WBCs, but most of their focus are in the platelets. Now, obviously, we have the new recommendation, and they are doing the same, but they have added the newer medications based on a newer evidence. When they say mild, moderate, and severe, basically, it's a numerical base. So if we are saying severe, it's basically less than 20 to 30,000 of platelets. And this is their statement, the statement 7. And actually, if you compare it with the previous recommendation, you will find it's almost the same. So it hasn't changed a lot. If the patient has severe thrombocytopenia, you have to go with high doses of glucocorticoids, plus or minus the IVIG, plus or minus the rituximab or cyclophosphamide, and then you go through with maintenance. Now, the interesting point that they have mentioned here, or they actually added as a reference, is actually from not of our studies, it's actually from hematology. So they have in the New England Journal of Medicine a recent reference by our colleagues, the hematologists, where they used MMF in a randomized controlled trial way. So we don't have that in rheumatology. We're using MMF all the time, but we don't have it actually in a randomized trial. So they actually divided patients between two groups, the group that they have the standard of care, which is the steroid alone, and the other group where they added the MMF. And as expected, the patients who had the MMF from the get-go, they did better in terms of less relapses and better response. So actually, this is a proof of concept rather than a new evidence. I mean, we are using it all the time. But this is a proof of concept that once you add it early, as we all rheumatologists do, you'd probably had a better response. So in a practical way, what we are doing, so if you have a mild thrombocytopenia, usually we will just watch. I know that it's not something very nice that you have a suboptimal level of platelets and then you have to go and live with it. But basically, if you're having the levels below 30, or if patient is anticoagulated below 50, to consider the active treatment. So some of the things that we don't deal with on day-to-day basis. So platelet transfusion, this is something that we might consider if the patient is actually bleeding, or they are going for an invasive procedure and you are afraid that they're going to bleed, or the platelet levels are less than 20. So these are the important things. Unfortunately, there is no way that we can predict which patients are going to bleed and which patients are not. Now, the glucocorticoid and IVIG, and I think this is an important message, is that when you give glucocorticoids, even the pulses of steroid, you're not expecting the platelets to go up right away, so don't panic. It might take a longer duration. However, the IVIG is something that actually would work faster. The problem is that IVIG is not available all the time, and it's a bit expensive. It's unlike steroid. So, but if you have a severe thrombocytopenia, if you have a bleeding patient, this is the way to go. The choices of glucocorticoid, it's always interests me in how rheumatologists deal with the steroid and how our colleagues do deal with the steroid. So obviously the hematologists like the dexamethasone. And as you can see, the interesting point, the second point, is that if you actually give dexamethasone 40 milligrams, it's almost equal to 280 milligrams of prednisone. This is like a very huge dose, but they do it all the time. So the dexa does work faster, does have its own glamour. However, our usual prednisolone dose is something that we can titrate and move around it easily. Now, what I have to say about the second line options is the TPOs, the thrombopoietin agonist treatment, and the splenectomy that's been used in an ITP. All I have to say is that in lupus, you tend to use the thrombopoietin agonist before splenectomy because of the possible side effects in the future. The other point is that thrombopoietin agonist does have higher risk of thromboembolism. So in patients with positive antiphospholipid antibodies, it's wise to avoid it if you can. Now, regarding anemia, you will treat it according to the cause. So basically, if you have a deficiency, you will replace it. If you have a renal impairment, then you will give the erythropoietin. And if you have an autoimmune hemolytic anemia, you almost deal with it as if you are dealing with thrombocytopenia. So it's still the steroid, the IVIG. You don't use the thrombopoietin agonist, obviously. But other than that, you almost use the same agents we are using for thrombocytopenia. Now, regarding the leukopenia, now I have a conflict here because I rarely treat someone only with leukopenia. I mean, if you have a well-controlled lupus behaving very well, but they have a WBC of 2,000, are you going to treat them? I know that numbers are, and even the patients, they are preoccupied by normal number as per the reference. But usually we don't treat them unless if it's actually apart from an active disease. So if they have a pancytopenia, we should think of an infection or a bone marrow involvement. But in case of the neutrophils is less than 1,000, these are the agent. One thing I have to say about the growth colony stimulating factor is we don't use it all the time, or we tend to avoid it. And the reason behind that is this old reference by Michelle Petri, as she noticed that if you use GCSF in lupus patients, they tend to flare up. And this actually was a very limited number. And then there was a question on why would they flare up? And these are some of the theories, is that probably, because of the activation and the more neutrophils you're giving, then this would in a way result into an active lupus. So the suggestion is, and again, there is no randomized control trial, is that if you have to use it, you have to use it. In a sick patient, septic patient with neutropenia, febrile neutropenia, then you have to use it. But other than that, try not to use it. Okay, so I think I reached my conclusion. So always consider and think of other causes like an internist. Think of the infection, think of the possibility of malignancies, and then the autoimmune processes that we're supposed to know it. And you always have to consult your hematologist. I think we are lucky enough that we have a hematologist in the house, so probably we're going to ask him about his insights as well. Leukopenia is common, but it rarely leads to infection, and it rarely needs treatment on its own. And now regarding the autoimmune hemolytic anemia and thrombocytopenia, they are usually have many causes that might result from, but you should go also and rule out one by one. TTP is something that can be deceiving, so always keep a high index of suspicion and think about it in the right clinical scenario. And thank you very much.